So I've been asked to discuss a topic related to cardiovascular critical care delivery, and in particular to sort of postulate on what the future cardiac intensive care unit should look like and how it should be staffed and structured and to deliver care to an increasingly complex population of patients. So it's evolved considerably since what it looked like 2 decades ago, when it was basically a box with a hole in the wall where a defibrillator would move back and forth to take care of patients after a myocardial infarction, shocking them should they develop a life-threatening rhythm disturbance, and that was it. So in a relatively short period of time, it's really evolved into an intensive care unit for patients that happen to have cardiovascular disease. But as the patients have evolved in complexity, as the procedures have evolved, so too have the needs of those patients. And again, the units have, in a lot of ways, mimicked the other intensive care unit settings, although they have a focus on cardiovascular disease, which adds another layer of complexity. In a lot of ways, I think units have to be structured to take care of an increasingly complex population of patients who are going to have longer ICU stays, who are going to require more critical care resources, ventilators, central venous catheters, end organ replacement systems like dialysis, extra consultation, mechanical circulatory support devices. So you can imagine these units have to be big enough to support that. As patients are there longer, we have to think about patient quality of life as well, so they have to be big enough to allow families to be present. They have to be able to facilitate an increasingly a larger and larger team of providers, which includes not just physicians, but critical care nurses, pharmacists, case managers, respiratory therapists, perfusionists. It's not just a unit staffed by a single nurse as it started out back in the 1960s. It is a unit that has to house a lot of different features from a patient and care team perspective. I think we've made great strides in understanding the challenges that exist and the challenges that are ahead. And I think, fortunately, we've gotten very good at managing certain conditions in patients that find themselves in the ICU. So look at our management of acute coronary syndrome. We know a lot about that and the management of those patients. Turns out the patients with acute coronary syndromes, or STEMIs in our unit, tend to actually bring down our morbidity and mortality. They're the healthy ones. It's now sort of exploring these other patients that don't have as sort of concrete, biologic pathway, not such a concrete treatment algorithm. The ones that start to develop not just single organ injury, but multi-system organ injury. The way to understand that, I think we're light years behind in terms of sort of developing optimal care processes for those patients. I think most of us that do this, you ask if we're in a good spot. I think we're in a comfortable spot, at least. Things could stay the exact same way, and our outcomes would probably be very similar. But I don't think that's the right thing for the patients. And I think you'll find that most of us in this field are uncomfortable being comfortable, and that's a good thing. So I think there's a lot to learn and a lot of evolution still to come.